So just some disclosures with nothing really related to the talk today, but just for purpose of full disclosure, the different groups I'm working with. So I'll spend the first part of the talk kind of giving some background on ALD, because I think that's really critical for understanding the kind of some of the logic and process behind newborn screening. And then in the second half of the talk, really get into a little bit more of the nitty gritty about newborn screening. So ALD is X-linked adrenoleukodystrophy. It's caused by mutations or variants in the ABCD1 gene. It's a gene that makes a protein that transports fatty acids in a part of the cell called the peroxisome. It's on the X chromosome. And I'll show you a slide in a couple of minutes, just what that means, kind of in terms of inheritance. The incidence is approximately 1 in 15,000 live births, so it varies a little bit based on just different groups have reported different incidences, ranging all the way down to like 1 in 8,000 live births to as high as like 1 in 20,000 live births, so kind of averaging around 1 in 15,000 live births. So a state of the size of Utah, which has a high birth rate for its population size of 50,000 live births a year, we're seeing approximately 4 new patients a year through newborn screening. ALD affects both sexes. It affects all races and ethnicities. So it doesn't matter if you're from China or from the United States or from Australia, you're still at risk for ALD. And then the key kind of biochemical test is something called VLCFA, or very long chain fatty acids, and that's a blood test. So as I mentioned before, ALD makes a protein that helps move fatty acids into the peroxisome. So the peroxisome is a part of the cell that kind of is responsible for kind of metabolizing fatty acids. And so that's critical for kind of like energy production in the cell. And so when the peroxisomes aren't working because the ABCD1 gene is not working, then it affects how fatty acids get used. And it ends up affecting multiple different parts of the body. Of course, kind of historically and kind of the way we think about these diseases, that affects the brain, affects the white matter, the myelin. ALD also affects the adrenal cortex. So people are at risk, or men are at risk for something called Addison's disease. The stress hormones aren't working. Can also affect the testes and affect sperm production. So this is just kind of a picture. So the top here is kind of a picture of what it would look like inside the cell. The little green dots are little peroxisomes inside the cell. So each cell has lots of peroxisomes. On the left here is a schematic. So these little green balls are the peroxisomes. And if you kind of zoom in closer, the fatty acids move across through different biochemical steps and then ultimately get moved into the peroxisome for this beta oxidation step. And if the protein's not working, then the peroxisome can't get those fatty acids and can't kind of do this important step in metabolism. So this is a schematic drawing from Stefan Kemp in the Netherlands of all the different mutations that have been found in the protein. And so the key thing as you look at it is that these mutations are just like all over the place. And so there's not one specific mutation type. And as we do more testing and are now screening more and more people, we're finding more and more mutations that we didn't know about. Sometimes it's really obvious what to do with those when we find a new mutation or new variant. And sometimes it's not so obvious. And I'll talk about that some more also. So this is just a reminder that the fact that it's on the X chromosome affects the patterns of inheritance and affects the risk. And so, for example, if a mother has the gene variant or has ALD, then she can pass it on to her son or to her daughter. So kind of a 50-50 risk for having an affected daughter or having a affected son. But if the father's affected, because he passes on his Y chromosome and not his X chromosome, only the boys would not be affected if there's an affected father. whereas the girls would always end up getting the affected gene. So just a little, not super complicated, but sometimes you have to kind of stop and think about it. You're like, oh, wait, how does this work again? So that's how it's true for ALD, and it's true for other X-linked diseases. So there's many different types of ALD, and so the kind of umbrella term that we use is ALD, but it's become clear that there's some people who have genetic variants, so changes in the gene, but they have no symptoms at all. And so they seem to be totally fine their entire life. And even for people who have a variant that we know can cause disease, most people with ALD, most boys won't have any symptoms at all, and no risk of symptoms for at least several years. The next type of thing that can happen with ALD is adrenal insufficiency. Another name for it is Addison's disease. And it's where your own body doesn't respond to stress, because your body has to be able to respond to stressors in order to kind of deal like with an infection or deal with like running a mile or something. And in severe cases, this adrenal insufficiency can be fatal, and the risk kind of goes up over time. The third type of problem that can occur in ALD is something called adrenomyeloneuropathy, or AMN. And this affects adults. It affects men more than women, but it can affect both men and women. And it's mostly affecting the spinal cord and peripheral nerves. Then finally, the most severe type and kind of the fastest progressing is something called cerebral ALD, or CALD. And it's an inflammatory progressive demyelination, so loss of the white matter in the brain. And it often presents relatively insidiously, so people don't realize that it's happening, but then symptoms progress very quickly and can lead to death within months to a couple of years. So ALD is confusing because the type of ALD, so from that list of symptoms, it's very difficult to predict what type someone's at risk for, or if they're at risk for all the different types. The screening that I mentioned, the VLCFA, which are the kinds of biochemical tests in the blood, its level just shows that you have ALD, but doesn't predict your risk for the type of disease that you're going to have. And the mutation, again, shows whether or not you have ALD, the mutation in the gene, but can't tell you your risk for cerebral ALD or not. So on the one hand, we can predict the presence of disease very well, but we can't predict the type of disease that the person's at risk for. And then finally, over the past 2 to 4 years, I'd say, as we, the community in the ALD world, have screened more and more people for ALD, in particular with newborn screening, it's become clear that there's many variants out there where there may or may not be disease. And so it's become very tricky now, in some cases, to tell families what to expect and whether or not they need to do all the steps that we recommend for ALD. So I think that the problems that the ALD community is facing with what to do with newborn screening results are problems that will, as more newborn screening comes out for Krabbe and for other diseases, that there'll be problems for the community. So in the way, they're good problems, but they do introduce another set of issues to worry about. Oops. So depending if you're a man or a woman, your disease course is variable. And so women, the disease tends to occur later, disease symptoms tend to occur later in life. So kind of after their 30s, or when most women start to become symptomatic, often into their 40s, and the slope, the curve, how fast the symptoms get worse is slower. Men tend to become symptomatic in their 20s, and the symptoms tend to get worse faster. Let's talk for a minute about, we'll kind of focus on boys and men for a couple minutes. So, so there's different, as we mentioned before, there's different kinds of disease types for ALD. So first of all, someone can be asymptomatic, and this is a little bit of a classical view, and our knowledge is becoming more nuanced as we kind of understand more about ALD, but it's kind of like a classical view. So basically, people, men with ALD are often asymptomatic, then over time begin to have symptoms. So what are their symptoms? So first of all, there's a risk for cerebral ALD. There's about a 30 to 40% risk of cerebral ALD in childhood, and there's another risk during adulthood. And so there's 2 periods of risk for cerebral ALD in a man with ALD's life. So the risk of Addison's disease seems to be kind of progressive over time. And so we don't know exactly, but it seems like more or less, the risk of Addison's disease is very high, like much more than 50% in men with ALD. And then finally, AMN also seems to be progressive and nearly complete, again, from this classical view of men who have ALD. And so that as you progressively get older and have ALD, that your risk of having these disease phenotypes also approaches 100%. Let's see if so with cerebral ALD, there's kind of 2 key peaks of age where men are at highest risk. So first in childhood, kind of during school age years, again into their 20s and 30s. With cerebral ALD, the key things that we see are that the MRI becomes abnormal. And so this example of a boy who had a normal MRI, then 3 months later, this is a part of the brain right here where it's kind of whitish in here called the corpus callosum. And so these are the first signs of his cerebral ALD. And then over time, the cerebral ALD can progress and involve more and more of the brain. And then it continues to progress. So without treatment, cerebral ALD is severe and fatal. And so within 2 to 5 years, over half of people who have cerebral ALD will die, and then also have progressive neurologic impairment. Cerebral ALD is treatable. And so essentially, if men are treated, or boys are treated at the first signs of symptoms, or even pre-symptomatically with the first appearance on MRI, the transplant is essentially curative for stopping cerebral ALD. In contrast, it doesn't seem to affect the risk for Addison's disease or for the AMN. So it's very unusual in that the transplant essentially cures the brain involvement, but doesn't seem to cure the other symptoms that men with AMN, with ALD have. Transplant only works in its early phase. And so if people are transplanted, if boys are transplanted at the early signs of disease, then it's essentially, fully survivable. Whereas the longer someone has symptoms, then the higher the risk of death or for the transplant not to be successful. And so the whole thing with transplants is a little bit complicated. Again, so with children with cerebral ALD, boys with cerebral ALD, then the therapy is transplant, and it's the kind of standard of care with the knowledge that it's only effective if disease is caught early, and after a certain point, both in symptoms as well as MRI involvement, meaning brain involvement, we know that transplant is not effective. With adult cerebral ALD, then it's a little bit more controversial. It should be considered, but the data is not there for really knowing who's the best candidates for transplant in adult men. And then for men who have AMN but no cerebral ALD, then bone marrow transplant is not indicated. And that's because the risk of transplant itself, it carries mortality risk. And so you'd be potentially putting people through a dangerous, complicated, and expensive procedure that they might never need in their life. And so there's indications that you should keep checking MRIs as adult men age, but then what to do with it's a little bit controversial. So we mentioned before about Addison's disease, how it's progressive incidence of Addison's disease. And so Addison's disease is, again, treatable. It's easily treatable. And without treatment, it can be life-threatening. And so it's a very, in addition to the cerebral ALD, the need to treat the Addison's disease made it very, made it possible to make a strong case for newborn screening for ALD. AMN is progressive and causes lots of health problems for men with AMN, but it's unfortunately not treatable currently. And so problems include problems with walking and balance, often kind of progressing to needing a wheelchair. The neuropathy is quite annoying and difficult to treat. And then urinary and bowel incontinence are major kind of impacts on quality of life for men with AMN. So for women, so for a long time, the burden of disease wasn't really understood in women, and I think we're still learning about that, but it's clear that women with ALD do have symptoms and they can be very impactful. So again, for women, the problem tend to have a later onset than men. And again, it's this AMN form. So women are not at risk for cerebral ALD and not at risk for Addison's disease, but women do develop AMN. The symptoms tend to be kind of mid to late 30s and then progress slower compared to men. But it's the same type of symptoms, so problems with walking, problems with neuropathy, and bowel or bladder problems. So let's talk, so we kind of talked about the disease itself, but then if you diagnose someone with ALD, what do you do? So basically, a very nice set of recommendations came out just late last year, 2022, about how to diagnose and manage patients with ALD. And it has recommendations for how often to do screening, what types of treatments to do. And it's in neurology. I highly recommend it for anyone who's taking care of ALD patients. So for Addison's disease, for the hormone issues, then the recommendation is to screen once or twice yearly. And then if there's any signs of Addison's disease, to treat with hormone replacement. And then for cerebral ALD, if the disease is caught early, then hematopoietic stem cell transplant is the recommended course of treatment and for boys. There are multiple clinical trials underway, including for vitamin D, for gene therapy, and for a drug called liraglutide. And those also may further kind of impact treatment options for men and boys and women with ALD. So newborn screening was, and I'll talk about more about the timeline, but it's based on biochemical testing from the blood spot, and it varies a little bit by state to state or even from country to country, but most laboratories kind of follow kind of this general paradigm where there's an initial kind of high throughput mass spec test for this, what's called the C26 lyso-PC, which is like a biochemical marker of the very long chain fatty acids. And if that's positive, then there's a second kind of higher resolution biochemical test, which is more precise and accurate. And then at that point, if both the tier 1 and the tier 2 screen are positive, usually at that point, the state lab is then notifying the primary care provider as well as a referral lab. And the referral lab depends a little bit on the state. So for example, in Utah, if there's a positive screen, then I get notified. If there's a positive screen in California, there's a network of biochemical geneticists that get notified. So it just depends a little bit on state to state and how they've set up their screening process. And so the testing, and then the tier 3 is kind of where it hits usually that's managed by the referral lab. So in that case, like that's managed by myself and our team, like Heather Fairfield, who's out there with you guys, Kristen Wong, our genetic counselor, for kind of what the next steps are for confirming that it's ALD, or there's other rare disorders that can be picked up, or if it's something else. So New York was the first state to roll out newborn screening, and thanks to the work really of Elise Seeger, shown here. And so she lost a boy to cerebral ALD, and I think realizing that it's screenable and that there's a treatment for it really kind of motivated her. And I mean, it's hard to give enough credit for all the work she did to help push this both to RUSP and then to different states. So this New York State implemented this at the end of 2013. And then 2016, ALD got added to the recommended uniform screening panel. It's occurring in other countries as well. In the Netherlands, it's occurring in men or in boys, I guess I should say. It's occurring in Taiwan, and there's pilot studies occurring in Italy and Japan. I will just point out that even after, and I think this was kind of an important point from the earlier discussion, that even after the RUSP adds a disease, that it's still up to the individual states to implement it. And so based on budgetary limitations, based on kind of the local advocacy efforts, different states have had very different timelines for implementing or not implementing the ALD into the newborn screening process. So this is as of basically this summer, the entire country in the United States showing which states have implemented newborn screening for ALD. And you can see the little arrows that show you the different dates of implementation. And so, for example, in Utah, we presented this very early to our state newborn screening lab, and basically it got approval at the screening lab, and then it got taken to the legislature. The legislature has to approve it, and then, but then we still had to wait for funding, and then we had to wait for the newborn screening lab to kind of implement the testing protocols. And so there's still like a time lag to move from, acceptance of the idea to actual implementation of the process. And so this is an example, and this is probably outdated now for what kind of how New York has dealt with the screening. So the screening, of course, there's the initial screen, which shows the possibility of ALD, but then there's other genetic disorders that can kind of have the same initial biochemical signature as ALD. There's also the risk for false positives. And so there's like a fairly complex algorithm that they've developed for working through if it's ALD or one of these other disorders. Just from a kind of statistical likelihood, it's most likely to be ALD because ALD is the most likely, the most common of these different what are called peroxisome disorders. But we in other states have all had the experience of someone who's had the initial screen positive and then been a different disorder or not kind of panned out to be anything, and that's been a little bit complicated. So just to highlight again, there's many different peroxisome disorders, and they have the same initial kind of biochemical signature. And so there's kind of subsequent biochemical testing that can help differentiate them, as well as genetic testing to kind of confirm or that it's ALD or confirm that it's a different disorder or show that it's a false positive. So what happens after a positive screen? So if we get referred someone from the state lab, then the next thing we do is we look at the very long chain fatty acids, but with knowing that at least in girls or women, that there's that the sensitivity of very long chain fatty acids is not perfect, and so they can have false negatives. Also, because of the risk for Addison's disease, and because we're doing a blood draw, we often do a cortisol and ACTH check at that initial visit with us. And again, this is because it's just a little bit harder to, and this is more of a process standpoint. It could, the cortisol and ACTH, you could wait till you get a confirmation that it's ALD because of kind of workflows and how spread out we are. It's easier to get it at the first visit. And then really a key step is this DNA confirmation. So of course, in some way you want to test the ABCD1 gene. There's different gene panels that often test not only ABCD1, but test a bunch of different peroxisome diseases. And so we often send that panel because it tests ABC1, but also tests a bunch of other genes. I think as genetic testing gets faster and cheaper and more comprehensive, I think more and more places, including us, will move to what's called whole exome sequencing and then whole genome sequencing, which will hopefully simplify some of the confusion. There's not much confusion around genetic testing. Usually it's pretty straightforward, but there are still some caveats. So for example, there are other peroxisomal genes that can cause the same biochemical signatures. So you need to be aware that those genes exist and could give you the same biochemical signature. It's also clear that even though they're not peroxisome genes, that these genes that cause something called Aicardi-Goutieres syndrome, or AGS, can also show up positive in the newborn screening. There's not very often, but sometimes there are patients who have ALD where the individual sequence of the gene's okay, but they might have like a duplication of the gene or some sort of large-scale chromosome rearrangement that the sequencing can't pick up. And so you have to get something called a karyotype or a SNP microarray. There's also new evidence that something called mosaicism can happen. So the DNA is just kind of complicated some days. And so in some rare instances, probably less than 10% of the time, we have to kind of chase stuff down the molecular rabbit hole. And there's two other chemicals that are sometimes used in the screening process. They're called plasmalogens, phytanic acid, and they can help kind of sort out the different kinds of peroxisome disorders if it's not ALD. So just to conclude, ALD newborn screening has been a key to saving lives for this disease. After that initial screen, extending very long chain fatty acids and genetic testing are the kind of the key next steps. However, it's clear now that there are other reasons for positives, not only false positives, but also other disorders that can have the same biochemical signatures. What are our challenges? So one problem is that the way the testing's done, both the biochemistry and the process, is very different from state to state. So the way Utah does its newborn screening compared to Idaho just being like the next state north, is very different. And so we get different kinds of results. Also with newborn screening, we suddenly realize that this disorder is a lot more complex, and we're having to kind of learn as we go about how to counsel families. And then finally, even with kind of confirming that someone has ALD, what their lifetime is like, what their risk for different kinds of disease is variable. And so that means that for families, we don't have a crystal ball, and that's can be really frustrating. I mean, we do the best we can, but we don't have perfect answers. So thanks everybody for your attention, and happy to take any questions, and look forward to seeing you in person in the near future.